Hi, my name is Laura McDonald, and the following presentation will outline the implementation of a quality improvement initiative for my Leadership in Healthcare Systems practicum at Grand Canyon University. Aurora Medical Center Burlington is a licensed 123-bed acute care hospital located in Burlington, Wisconsin. The hospital consists of 3 inpatient units, which are 2 med-surg and 1 for ICU, that serves a patient population of adults aged 18 and older. Typical daily inpatient hospital staffing is for a maximum census of 43. Aurora Medical Center of Burlington has been part of the Burlington community for 100 years and is licensed as a Level 4 trauma center, a primary stroke center, and has age-friendly certifications for both the emergency department and inpatient units. The primary hospital inpatient population is geriatric, which is patients aged 65 and older, and this was what prompted the pursuit of the age-friendly certifications. Aurora Medical Center in Burlington is owned by its parent organization, Aurora Healthcare, which is a health system with locations throughout Wisconsin. In recent years, Aurora Healthcare merged with Advocate Healthcare in Illinois to become Advocate Health. Advocate Health then recently expanded their footprint to the southeastern United States. Advocate Health's headquarters are in North Carolina and consist of hospitals and clinics that stretch across 6 states, with a strong organizational presence in the Midwest in both Wisconsin and Illinois. Advocate Health is the third largest nonprofit health system in the United States and provides care to over 6 million individuals and employs almost 162,000 teammates. Organizational goals include fostering clinical excellence, particularly in patient safety and experience, improving the health of their communities, providing accessible and affordable care, investing in teammate growth, and advancing patient care. The purpose and commitments of Advocate Health are important to understand when choosing an appropriate topic that will fit into the organizational goals and culture. Teammate behaviors include lifting everyone up, leading the way, thinking boldly together, and embracing the unknown. By addressing potentially preventable readmissions, patient care is being improved, innovative solutions are being implemented, teamwork is cultivated, and opportunities for learning are embraced. Currently, 1 out of 5 Medicare beneficiaries are readmitted within 30 days, with an estimated cost of $17.5 billion annually. The Centers for Medicare and Medicaid have started penalizing hospitals with high readmission rates under the Hospital Readmission Reduction Program. While readmissions may also be due to a worsening of a chronic illness, they are often attributed to issues with management during the index hospitalization or uncoordinated discharge processes. It is widely understood that the United States healthcare system has several gaps in care and requires a significant overhaul. In 2008, the Triple Aim was created to guide healthcare organizations to redesign healthcare systems and transition to population health from an episodic system. These goals include improving patient care, improving health of populations, and decreasing the cost of healthcare. Keeping in mind the goals of the Triple Aim, a project that would address care coordination, delve deeper into hospital readmissions, and address patient or family concerns is pertinent to meeting these goals. The needs assessment that I conducted identified an acute rise in readmission rates, decreased patient satisfaction scores, process breakdowns, particularly with discharge coordination and communication, and misaligned site quality improvement projects with broader organizational goals. Following the needs assessment and the evaluation of project topics, it was determined that addressing rising readmission rates was imperative. The goal of this project focuses on reduction of hospital readmissions within 30 days at Aurora Medical Center in Burlington. Advocate Health's system goal for readmissions was 0.84, with the most recent available quality metric data from Aurora Medical Center of Burlington not meeting target and rising at the time of the needs assessment. The data that was utilized was data from May, where Aurora Medical Center in Burlington was at 0.86, to July, when they went to 1.27. This project was initiated at the beginning of my practicum course in September. This project topic choice meets the mission and vision of the organization due to the potential positive impact on patient experience, satisfaction, and safety. It is also aligned with the organizational goals and commitments of Advocate Health. As a solution to not meeting the organizational target for readmission rates, bedside readmission huddle implementation was proposed. In current state, Aurora Medical Center Burlington currently holds a readmission huddle weekly. However, this is done via a Microsoft Teams meeting and does not incorporate the attending physician or the patient and family. Readmissions are reviewed and discussed from the prior week, and interventions are proposed to decrease the likelihood of readmissions in the future or identify trends or breakdowns in current processes. Due to the retro review of these cases, proposed interventions usually are unable to be implemented in real time. The proposed practice change is to initiate a bedside huddle, including the assigned case manager or social worker, registered nurse, and either the physician or advanced practice provider, to be held within 24 to 48 hours post readmission. Ad hoc teammates will consist of pharmacy, therapy, and home health to be pulled in at the discretion of the primary team. Huddle inclusion criteria include patients that are readmitted as an inpatient within 30 days of a prior inpatient readmission at Aurora Medical Center, Burlington. The huddle will be led by the following case management teammate and seeks to identify short-term interventions, such as what could be implemented or changed now, and long-term issues, such as how is our organization providing care or any systemic issues. Short-term interventions would be assigned for follow-up and tracked, whereas systemic issues would be brought forward to the weekly readmission huddle for further discussion. Following huddle completion, the following case management teammate will document a concise huddle summary in their plan of care note, which will discuss the identified reason for the readmission and any interventions that will be implemented for the current discharge plan. Supporting evidence for the implementation of bedside readmission huddles is beginning to grow. South Regional Healthcare in South Carolina saw a reduction in their low acute, non-emergent emergency department visits and achieved a 3% decrease in their all-payer readmission rates in 1 year. Additional successes included an increased awareness and collaboration regarding hospital readmission and the implementation of physician-led teams to rectify identified site-specific trends such as COPD management and medication reconciliation. Goals of implementing bedside readmission huddles are listed above. Disjointed communication amongst the healthcare team and between the healthcare team and patient and family unfortunately remains a challenge. By pulling the team together with the patient and family, the team presents a united front and encourages collaboration to improve patient care and outcomes. Collaboration between the healthcare team allows for more seamless transitions of care, which will decrease the likelihood of a negative outcome. Early identification of risk factors that led to the readmission is critical to inform current discharge planning efforts to ensure a successful discharge plan. Patient education is key to ensuring the patient and family feel comfortable with the plan and confident of their ability to successfully rehabilitate following the hospitalization. And the final goal of this project is to impact the 30-day readmission rate at Aurora Medical Center in Burlington to provide high quality, safe, and cohesive patient care to our community. When working through the implementation of the project, there were 3 main challenges that were identified with unplanned 30-day readmissions. These included disjointed care coordination and discharge, high potentially preventable readmission rates, and decreased patient and family satisfaction scores. Coordination of patient care transitions is a significant challenge to healthcare providers nationwide. By implementing this project, the team seeks to provide more cohesive transitions of care from the hospital to the community. Despite ongoing efforts to improve patient satisfaction scores, there remains disproportionate scores between high rates of patient satisfaction with doctors and nursing staff and low likely to recommend the hospital scores. By implementing this procedure to address disparities in care, identify processes that may require modification, and personalizing subsequent discharge planning processes, it is anticipated that there will be improvement in patient satisfaction scores. The final anticipated outcome is to meet the target organizational readmission rate and reach to stretch to drop below that target. Stakeholder reception was overall positive. Case management was engaged, looking forward to the goal outcome of increased multidisciplinary team engagement. They identified wins at check-ins, stating that families appeared to appreciate the coordination of care between the multidisciplinary team. There were several instances where the patient's voice feeling more comfortable with their plan moving forward after attending the huddle. Physicians and advanced practice providers were overall receptive as well, with some resistance due to concern for fitting huddles into their workday. Nursing staff struggled to be available to attend these bedside huddles. However, it was found that information shared during morning rounds could be relayed by the following case management teammate. Leadership was enthusiastic about the project, particularly due to the potential impact on quality metrics and patient satisfaction scores. To achieve sustainability of the project, it is imperative to evaluate the clinical practicality of the project. Quality improvement in healthcare is complex, and it is critical to include healthcare providers, patients, and families when identifying gaps in healthcare practices, developing interventions, evaluating the outcomes, and determining the value of these interventions and outcomes for all parties involved. For my project, I sought to elicit input from the multidisciplinary team throughout the trial period to determine if this was a value add practice change. Sustainability of the project is more than just ensuring that the workflow is practical. It needs to be effectively implemented and sustained. Leadership needs to provide support and education to the bedside staff regarding that practice change, and there needs to be ongoing training for staff and monitoring of the outcomes. It is also important to ensure that key stakeholders understand the why behind the practice change and receive timely follow-up with the outcomes that are being achieved due to their efforts. Change is a constant in healthcare, and leaders need to equip their team with the tools to understand, manage, and adapt. The project pilot was launched on week 12 of my practicum experience. I was available on site 2 days that week to provide support to the teammates as they launched the project. The case management department began assessments in preparation for the launch of the bedside huddles on Monday, Tuesday, with a plan to have the first huddle held on Wednesday, December 10th. I coordinated with my preceptor and the case management leader to receive feedback on documentation and any initial wins or areas of opportunity. My initial follow-up goal was 2 cycles of biweekly evaluations, then increments of 1 month, 3 months, 6 months, then annually, unless there is a significant issue identified with the process requiring modification. Following the evaluation, if there are clear needs to modify the process, this will be completed and the cycle will be rerun. I held my first roundtable discussion with case management teammates on Friday, January 5th, and I followed up with the leaders of quality case management and nursing. I elicited further feedback from the leaders' perspective after discussions with their staff. Identified issues for consideration were modification of inclusion criteria and adjustments to the composition of the core team. The project will be handed off to the quality nurse assigned to readmissions and the case management leader. This team will hold ongoing discussion of necessary modifications to the process and will provide education to key stakeholders. The project will be then relaunched and ran through an additional plan, do, study, act cycle with appropriate follow-up from the team. The readmission task force meets weekly and is an ideal opportunity to discuss bedside huddles, provide value insight for key takeaways, and report wins to the case management staff and nursing/physician leadership, such as patient engagement and satisfaction, readmission rates, etc. If implementation is deemed to be successful, there are plans to expand this process to Burlington's sister facility, Aurora Lakeland Medical Center in Elkhorn, Wisconsin. Widespread change, healthcare reform, and the COVID-19 pandemic have all impacted nursing leadership. The American Association of Colleges of Nursing Essentials outlines nursing professional practice and includes several domains which I have translated into my professional goals. This project helped me meet several of these professional goals, including experience in patient-centered care, quality, safety, interprofessional partnerships, professionalism, and leadership development. For person-centered care, I built this project to increase collaboration with the patients and families in their care. This was an identified deficit in the current readmission review process, as this planning is generally done post-discharge. By focusing on a pertinent quality metric, I met my goal of providing safe and quality patient care. I strengthened my skills in interprofessional partnerships by including the interdisciplinary team through several avenues and seeking their input regarding the project during planning, implementation, and evaluation stages. My professionalism skills were also enhanced as I was approaching teammates as a leader rather than a peer, while learning from my preceptor how to garner and maintain stakeholder support. My leadership development skills were also enhanced through the day-to-day activities with my preceptor. The American Organization for Nursing Leaders Nurse Executive Competencies are 5 competencies that are critical to outline the knowledge, skills, and abilities that nurse leaders must possess and exhibit regardless of their practice setting. During this project, I met all 5 competencies. The first competency focuses on communication and relationship building, which was critical in the topic selection, project planning, implementation, and evaluation stages. This required relationship management with key stakeholders, clear and effective communication, and influence over behavior modification. Second, knowledge of the healthcare environment focused on clinical practice knowledge, as I pulled from my past experience as an RN case manager, evidence-based practice, outcome measurement, patient safety, and performance improvement of quality metrics. Next, the leadership competency was meant due to my utilization of critical thinking skills, planning for project handoff, and change management techniques. The professional competency was met by showing up with authenticity, flexibility, and accountability that I needed to exhibit during this project. Finally, business skills include financial management, such as the budget for the project, and understanding of financial impact readmissions may have on the organization, and IT management by building documentation in Epic with the case management leader post-Huddle. Throughout this project, I learned and grew in several aspects as discussed in the previous slide. The lessons that I learned from this project are listed here. First and foremost is the engagement of stakeholders early and often. I learned gaining their buy-in, hearing out the most critical opinions of the project, and seeking input frequently was very important. I also learned that project management structure helps keep projects on task and staff focused to meet deadlines. Aurora Healthcare utilizes SBARs to bring new processes forward to leadership, so this project was valuable to gain this experience. Utilization of the PDSA cycle helped structure the pilot of the program and allowed for modifications and additional trial runs of the process. Next, projects are only as good as their sustainability. Too often, I have seen new processes be introduced, partially adopted, and then discarded. By planning for structured evaluation and dissemination of outcomes to the key stakeholders, this will help maintain the change or determine if the process should be modified or discarded. Finally, the importance of a visible and engaged leader was further reinforced. Leaders that are visible and engaged result in teammates who are highly engaged in patient care and quality improvement initiatives. As a quick wrap-up of my presentation, I discussed the development and initiation of bedside readmission huddles at Aurora Medical Center of Burlington. This setting is a community care, acute care hospital setting with a primarily geriatric population, which has been challenged with a recent increase in their 30-day inpatient readmissions. Stakeholder support of the project was overwhelmingly positive, which led to early adaptation of the project and multidisciplinary support of this initiative from leaders. During check-ins post-pilot implementation, it was reported that patients and families voiced appreciation for the communication and coordination efforts during huddles. Utilization of SBAR and PDSA were critical in providing structure to the project, and a sustainability plan and handoff was created with input from the quality, case management, and nursing teams. Identified areas of improvement that were handed off to the team included a reevaluation of who should be included in the core team and increased parameters to inclusion criteria for the huddles. And that concludes my presentation. If you have any further questions or comments, I have provided my email on this slide. Thank you so much for your time and attention.